Hello, my name is Dr. Joseph Mikhael. I'm a hematologist at the Translational Genomics Research Institute, and it's a privilege to be here at the American Society of Hematology meeting. I'm going to share with you a few thoughts about major advances in multiple myeloma that have been presented here at the annual meeting. We're going to think quickly of three topics. First of all, daratumumab-based combinations. Secondly, bispecific therapy. And then thirdly, CAR T-cell therapy. Daratumumab, of course, is a monoclonal antibody directed against CD38 that we use very prolifically in the clinic already, and we use it literally at all stages of myeloma. But we've seen here even further advancements of this agent in several combinations. In fact, the late-breaking abstract for myeloma this year is the CANDOR study, which combines daratumumab and carfilzomib together in early relapse in multiple myeloma. And this, I think, is going to be particularly important in the future, as we very often use a VRD-like or VTD-like combination, followed by transplant or not, and then lenalidomide maintenance. And when patients have relapse on lenalidomide maintenance, it would be ideal to use a non-immunomodulatory combination. And so I think this combination is something we're going to use quite extensively. We've also seen daratumumab presented in the frontline setting, in addition to bortezomib, lenalidomide, and dexamethasone. The Griffin study showed that dara-VRD was superior to just VRD alone. This could well be a new standard of care of using this quadruplet in patients who are eligible for an autologous stem cell transplant. So furthermore, we even saw daratumumab with combinations for transplant in eligible patients, in particular being combined with ixazomib, another proteasome inhibitor, with lenalidomide and dexamethasone. So really, we've seen more use of daratumumab right across the myeloma spectrum. Secondly, we've seen the next generation of bispecific therapies. So these are agents that not only like a simple monoclonal antibody hold on to the disease, they reach out and engage a T cell. And so we've seen several bispecific therapies for myeloma over the last couple of years, and here a new agent is being presented that has been very well tolerated and much more conveniently delivered than the early bispecific therapies that required continuous therapy, by being able to give an infusion every 1 or 2 weeks so that it's more convenient for the patient. This could be particularly helpful in the long term, as CAR T-cell therapy can be difficult to access and requires apheresis and T-cell harvesting and manufacturing. This is an off-the-shelf-like CAR T-cell approach. And then finally, CAR T-cell therapy itself. We've really seen a revolution in CAR T-cell therapy in lymphomas and leukemias, and now we're starting to see it really take effect in multiple myeloma. And we've seen several new products presented here at the ASH meeting, and in particular, we're noting that there is dramatically less adverse events than we saw in the earlier days, much more controlled cytokine release syndrome, and particularly good response rate, including the CARTITUDE study, which demonstrated literally 100% response rate. Now, obviously, these are smaller numbers. We'll have to gain more information, but this could very much be an important feature for myeloma patients, as we can not only employ their own T cells, but have them continuously used to control this awful disease.